Now we're going to come to gender differences and neurodevelopment as a whole, because it's really important. When we have this foundation, when we apply the diagnostic hierarchy, things will become easier. Males have a very different phenotype, even from an EEG perspective. So what you see here is it's known as a developmental deviation model. And here, what you find is that the maturation is not necessarily lagging, but that it is not approaching normality or maturation, and that it is unlikely to do so at any stage during the lifespan. Now, this is, of course, for males with quite significant ADHD type phenotype. But what I want to highlight here is this widespread theta activity. It's widespread. They use a marker for improvement known as frontal theta. So when there is adequate frontal theta, which is nothing but frontal top-down inhibition. You see here theta widespread. Theta is 4 to 7 hertz, correct? Just above the delta slow waves. When there is adequate frontal theta, it's a marker of good top-down inhibition. And that's exactly what they're measuring in that Endeavor treatment. So that's for males, the developmental deviation. Females, on the other hand, it's really interesting, is they show greater involvement of central and autonomic function. This is so important in clinical practice because many females will have diagnosis of anxiety, arousal, borderline personality through their impulse discontrol, emotional arousal, heightened emotional sensitivity, heightened rejection sensitivity. You will see diagnosis very commonly of bipolar 2. Now note, doesn't mean we're not looking at, hey, do they have bipolar 2 or do they not? We can make a difference to their prefrontal cortex functioning and emotional regulation through appropriate targeting. But very commonly, I find that bipolar 2 diagnoses are there and the patient's having a number of residual symptoms. One of the clues that often tells me that I need to go a bit deeper into this reward deficit cognition activity is that they're often on a very small dose of an antipsychotic medication. I examine them and they're having cogwheeling. Or when they're talking about cognition, they're talking about significant slowing out of proportion to what I would normally see. I'll do a Luria 3-step and I see significant slowing, right? So it's out of proportion. And remember I mentioned, when they've got a reward deficit state D2 and you add a D2 antagonist, they have an exaggerated side effect profile than others. So this is one of the places where the red flags that tells me, hey, I need to go a bit deeper into this, okay? So note that in females, it's an arousal model predominantly, which is why in treatment, almost always, I find myself needing to prescribe a mood stabilizer as a buffer before considering a stimulant, or not necessarily always before, but as a buffer to control that arousal. Now, this could be mood stabilizer, or it could be, we'll see tomorrow, alpha-2 presynaptic agonist to reduce hyperarousal. But that almost always gives a much better combination than if we simply go down the path of a activating agent. So just keep that in mind. I'm not saying in all cases. Some cases, a single stimulant will work, particularly the milder end of the spectrum. I'm talking about individuals when they present to you with significant anxiety, significant arousal symptoms. You'll find this particular picture.